If I could have your attention, please, and good afternoon and welcome to everybody here today to Eat Fact, Not Fiction. My thanks must go to Tom and the BDA Communications team and head office staff for bringing together this event prior to our AGM at 6 o'clock today. We've got an exciting lineup of speakers and I'll be kicking off first. My name, for those who don't know me, is Anne Holdoway. I'm a consultant dietitian based in the southwest of England, and I'll be kicking off first before we move on to our other speakers. So firstly, I'll just be setting the scene here in the Horizon at Leeds and talking about some of the background into what is happening in the modern healthcare environment and our healthcare landscape. I've been specifically asked to look at the burden of disease, the benefit of diet, and the role of the expert dietitian. And my experience in this field is based on 30 years' experience as a registered dietitian, spanning the commercial sector, the NHS, research, and clinical practice. And today, what I'm going to be talking about really is the actual role of the dietitian and the expert dietitian in the management of chronic disease, helping to improve quality of life in many individuals affected by chronic disease and life-limiting conditions around the country. Much of my experience in recent years is based on my work at Dorothy House. That's just to the right-hand side of this slide. This is the hospice based just outside Bath where I work. I've been there for about the last 4 years, and in that position I find that I'm really bringing together all of the expertise over my 30 years to try and support patients with life-limiting conditions, considered at the end of their life. But just to clarify, end of life these days is the last year of life, and palliative conditions now affect thousands of people in the UK, and they can be living with it for many, many years. So it's all about providing timely, appropriate nutritional care for these individuals to transform their quality of life. So I'm going to be drawing on some of my experience from that field in particular when I'm going to be talking about the burden of chronic disease and the role of the dietitian. I've also had the privilege over the last 2 months of hearing from many dietetic leaders at various events around the country, and what they've shown to me is some of the trailblazing work that's very evident amongst our profession in the field of things like childhood allergy, adult allergy, irritable bowel syndrome, cancer management, and other chronic diseases. And I hope it comes through today of some of the work that dietitians can do in this field in conjunction with significant others around us whose help we need to actually influence the agenda and actually improve the life and well-being of our population. So in the next 10 minutes or so, I'll be looking at the healthcare landscape, long-term conditions and chronic disease, just the burden of that to our healthcare environment, the impact of many of those conditions on dietary intake and nutritional status, and how I believe the dietitian can really make an impact in this field. I'm going to be concentrating on long-term conditions, and if we just think about that, at the moment in the UK, long-term conditions take up around about £7 out of £10 spent in the health and social care sector. They account for about half of GP appointments and about 2/3 of all patient in-stay days. When we think about chronic disease, these are things like diabetes, heart disease, stroke, and then also, if you think about some of the factors contributing to these chronic disease, obesity is probably one of the number one factors that we have to address. And here you'll see on this slide, our forecasts for obesity look fairly dire. In 2020, we're anticipating 8 out of 10 men and 7 out of 10 women being obese across the world. We'll hear later on from Mary talking about her role in bariatric surgery and the role of the dietitian in that field. And in terms of the impact of obesity, it's also rather worrying for some of the younger siblings too. And this is a letter written by a young child to David Cameron to ask him for some help in actually managing his sister's weight. Another area where we're seeing an increasing number of survivors is cancer. Cancer is expected to affect 1 in 2 of us being diagnosed with cancer in our lifetime. We are getting more effective at managing it and treating it. But in terms of survival, what we're now seeing is that many of these patients actually have long-term consequences of cancer treatments. In addition, we know that obesity can contribute to the development of cancer and recurrence. And that means there's a big role for dietitians in the healthcare arena to try and tackle obesity as well as manage the long-term consequences of cancer treatments going forward. We know that many life-limiting conditions will predispose an individual to malnutrition. But I'd like to emphasize that many of those long-term conditions will actually also mean that that patient will experience a number of dietary challenges, and I'll explore some of those areas as we go through. But in terms of fact and fiction, I'd like to debunk a common myth, really, amongst many of my colleagues and doctors in particular, and that is, that malnutrition is considered to be an inevitable part of disease and old age. And the fact is, it doesn't have to be. And we should be looking at actually preventing malnutrition from arising and then treating it effectively if it does rise. In terms of how many people that affects, we're talking about 3 million. That's about how many people read the Daily Mail and the Sun each day. So just to put the figures into context. And if we believe we're doing something positively in terms of tackling malnutrition, here's the latest fact that malnutrition accounted for 128,000 bed days in 2010 to 2011. That number went up by 40% in 2015 to 2016. So that's a reminder, really, that if we actually want to tackle malnutrition, we haven't done that much about it in terms of reducing the numbers over the last 5 years. One could argue that we've become better at measuring it, so that could account for the increase in numbers, but we've certainly got a long way to go in terms of actually tackling malnutrition, which is on the other end of the public healthcare spectrum to obesity. But I believe this fact that optimum nutrition, excellent nutritional care, and tailored dietary advice does have the power to transform lives. Do others believe in that? Well, increasingly we're seeing the role of dietitians and the role of dietary advice in managing chronic diseases and life-limiting conditions being referenced in important national documents like NICE guidance and quality standards. In addition, I believe that appropriate nutritional care has the capacity to meet all 5 domains of the NHS outcomes framework. And you could probably say the same too about effective nutritional care and optimal nutritional status actually achieving the same in public health. For many of my patients, the reality is that diet cannot cure them of their condition, but I believe it can play a significant role in symptom management and well-being, along with reducing health and social care costs associated with poor nutrition and malnutrition in individuals with life-limiting conditions. And another fact is that poor nutrition, malnutrition in particular, that causes consequences in terms of quality of life, activities of daily living and functionality, that malnutrition is what costs the health service a huge amount of money every single year, and yet we're still not tackling it effectively. These are the latest figures published by Professor Elia and the NIHR in 2015. And in England alone, the consequences of malnutrition, the health and social care costs associated with malnutrition were £19.6 billion, far more than what we actually have to pay out for managing obesity and its consequences. And just to put that into context in relation to our individual patients, a patient with a life-limiting condition or a chronic disease who's malnourished costs £5,000 a year more to manage than a person who's normally nourished. And therefore, I believe if our Secretary of State for Health actually understood those figures, what he'd be doing tomorrow is going out to recruit a whole host of dietitians, both in hospital and the community. The other issue that we're facing in our healthcare landscape is that multi-morbidity is a growing issue. And many of our older people beyond the age of 50 will actually be experiencing a number of chronic conditions. So it's not just one chronic disease, but they may be managing 3 chronic conditions. And in those cases where you've got a case of a patient with the consequences of cancer treatment, COPD and diabetes, I'd like to ask you, who is best qualified at tailoring that dietary advice to that individual and putting things like public healthcare messages into context? And we'll hear more later on about public health messages and the role of diets out there perhaps getting through to the wrong people. So I believe, because multi-morbidity is a growing issue, that dietary advice does have to become personalised using the expertise of dietitians, because one diet doesn't fit all. And if we're going to provide appropriate nutritional care for many of these individuals with chronic disease and life-limiting conditions, then that advice needs to be predictive of their condition, preventive of other conditions, and it needs to be personalised and patient-centred, so participatory. If we just look at some of the common issues facing many of our patients with chronic disease and life-limiting conditions, they're summarised here on this chart. And trying to deal with these when you may be socially isolated and ageing can be a real challenge. So I believe, as registered dietitians, not only do we work from an evidence base, but where the evidence is lacking, because we don't always have the randomised controls trials to rely on, that we utilise our knowledge of food and diet and health and well-being, what's in our food, physiological knowledge, the knowledge of biochemistry, disease management, health and well-being, all combined together to hopefully provide advice for an individual that is tailored for their individual needs and is both acceptable and practical. And I believe another area that people perhaps overlook in terms of the role of dietitians is that we're very effective educators. So when it comes to managing chronic conditions and life-limiting conditions, I feel the feedback I get from my patients is often about the fact that's the first time somebody's sat down to explain not only what diet perhaps would be beneficial to me, but the actual condition itself. But the reality is there are only about 9,000 registered dietitians in the UK, so it's clear we do have to work with others, but perhaps what we can do as dietitians to be effective is ensure that the knowledge out there is underpinned by good science and there's best evidence available. And in fact, learning from our colleagues over the water in the USA, we perhaps need to move towards the stratification of patients, so those that are most needy actually get our input on a one-to-one basis, whereas group sessions and self-management can be promoted to those who are less needy. So I believe nutrition does matter, and I strongly believe, with 30 years experience and the work I currently do, that dietary advice has the power to transform patient care. And I'm just going to spend a couple of minutes looking at where I believe we can have a real impact. If we think about our cancer patients going through treatment, we know that diet can help optimise tolerance to radical interventions and alleviate symptoms both during the treatment but also beyond it into survivorship. We'll hear more later on from Rachel about the impact of her work in the Durham area around education and management of nutrition in older people. We do know from clinical studies that good nutrition can maintain independence, reduce isolation through even such things as dining clubs. It can improve cognition, increase activities of daily living, and maintain independence. Most of us are familiar, if you get a new pair of shoes, not necessarily high heels if you're male, but how painful a pressure sore can feel. And so just imagine what this feels like. And pressure sores currently cost the NHS about £43 to nearly £400 a day to manage. My argument with these patients is if poor nutrition is stopping the healing of that pressure ulcer, then why is there not investment in community services of dietitians to actually optimise nutrition in some of these patients, where improved nutrition could increase the rate of healing and actually reduce the need for services like district nurses going in on a daily basis to dress such wounds. Another fact is that in conditions like chronic obstructive pulmonary disease, there's a plethora of evidence looking at the effectiveness of oral nutritional support on length of stay, hospital readmissions, infections, and mortality. And in the many patients who have neurological conditions, things like motor neurone disease, we know that appropriate nutrition can reduce the risk of aspiration and maintain the nutritional status of an individual safely and soundly. But I would argue that they need one-to-one dietetic advice and support for the patients and the carers to achieve that. We know that going forward, we can't afford to provide all our care in hospitals. And if we look at the average length of stay in 2014, it was less than a week. So the argument now should be that actually our focus should be on increasing the dietetic access in the community. And what can dietitians achieve in the community? I believe we can empower patients to self-manage their conditions, reduce the demand on GP time, and we know GPs are in a crisis at the moment, make prevention possible, optimise the use of nutritional products as well as medicines, reduce secondary care referrals, and reduce the need for hospitalisation, all utilising technology effectively to make us as efficient as possible. What we do well, in particular, and I think is fairly unique to what we offer, is that we consider all of the challenges around food from both the client and the carer perspective and look to support them to handle their dietary issues on a daily basis. I believe we are able to educate and motivate to enable individuals to achieve change, and we can offer individual advice and think about putting key messages and public health messages into context. And overall, I think we apply a degree of pragmatism in all of the cases that we deal with, setting mutually agreed, realistic goals to optimise quality of life, nutritional status, along with the enjoyment that we should derive from eating and drinking. And we mustn't forget that it's not all about just achieving adequate nutrition and optimizing nutritional intake, but food should be a pleasurable experience. For many of my patients, it may no longer be that, and it's about then supporting their individuals to cope with that along with their carers. So my key messages for today is that nutrition should be an integral component of care for patients with long-term and life-limiting conditions. I believe appropriate dietary advice can transform lives, and the evidence is there to support that. It can also transform the patient experience and is crucial for disease prevention and preservation of optimum health. It's true that probably one diet doesn't fit all, and which is why the wrong messages often get to the wrong people. We know that GPs are under a huge amount of pressure, but I think they need to look around themselves and look at the multidisciplinary team members available, because dietitians can help deal with some of the issues that our GPs are currently faced with tackling, and we might be able to deal with them more effectively. Without dietitians, I believe the NHS will remain a national sick service, and we have a lot to offer. But in terms of potential means nothing if you don't do anything with it. So I'd like to finish on the last note about fact and fiction. And currently, this statement in terms of how do we tackle some of our healthcare issues, quite simple. We need investment in dietetics and dietetic services. That's currently fiction. I'd like to ensure that our Secretary of State for Health going forward believes that that's fact. Thank you very much.